Well, thank you very much, Elise, and many thanks to the NET Research Foundation for inviting me to give a brief overview about how the COVID-19 pandemic has affected the oncology community. So in the next few minutes, I'm just going to briefly describe how this virus projected here has really upended all of our lives. This is a picture of the coronavirus, which is aptly named because of the crown-like projections at its surface due to the spike protein. Coronaviruses are a large single-stranded RNA viruses. There's a number of viruses in this family that infect humans that cause a mild upper respiratory virus. So this particular virus, SARS-CoV-2, which is responsible for the COVID-19 pandemic, has now exceeded infecting 33 million people globally with 1 million documented deaths. According to the New York Times in early October, 7.4 million Americans have been diagnosed and over 200,000 people have died in the United States. SARS-CoV-2 efficiently spreads from person to person via the respiratory route. And genetic sequencing has suggested that the virus has mutated to become even more efficient in spreading person to person. The strains in Europe have already been found to be different than the initial strains in Wuhan. And there's been a less transmissible Chicago strain that was identified that was very similar to the initial Wuhan strain, which makes sense as Chicago was the first case in Chicago was reported to be imported from Wuhan. SARS-CoV-2, while it can be found in blood, urine, and stool, it is a respiratory virus. And there have been no cases of bloodborne infections despite viremia, and as well as no cases of fecal, oral, or sexual transmission of the virus. The incubation period for SARS-CoV-2 is about 14 days, but the median is 4 to 5 days. Typically, the virus is detectable 2 days prior to symptom onset, and the viral load peaks right after the onset of symptoms and then declines within 7 days. 15% of cases are transmitted from asymptomatic individuals. The majority of cases, between 50 and 60%, are transmitted between pre-symptomatic patients. And there is about a 10 to 15% of transmission within household contacts. As we know, the transmission can be heterogeneous, and there's been well-documented super spreaders as well as super spreader events. And so while the virus can be detected in an individual more than 42 days out, this does not correlate with its infectivity. The severity of COVID-19 is extremely variable. About 80% of patients are asymptomatic or have very mild disease. However, severe disease develops in about 15% of patients. In critical illness, known as shock or respiratory failure, can occur in about 5%. Overall, the mortality was reported to be over 2% in Wuhan, China. So in New York, about 14% of patients that were hospitalized were treated in the ICU, and 12% of patients were on mechanical ventilation, which was associated with the 88% mortality. There have been several risk factors reported for patients developing severe disease when infected with SARS-CoV-2. This includes age, which is the most well-documented risk factor. In the United States, 80% of deaths due to COVID-19 have occurred in patients greater than 65 years old. Other risk factors include cardiovascular disease, such as hypertension, diabetes, obesity, as well as cancer. However, data on how immunocompromised patients do is limited, and we clearly have seen that there have been racial disparities about how this disease has affected our society. So turning to a little bit more towards COVID-19 and cancer patients, Cornell Medical Center recently published their experience testing asymptomatic cancer patients to see about the rate of COVID-19. And about 620 PCR tests were performed on about 537 asymptomatic patients. 90% of these patients were receiving active chemotherapy, and the rate of positivity was 0.64%, which it contrasts to the rate of positivity at New York City during this time in early May, which was about 20%. So thus, out of about 537 patients, only 4 asymptomatic patients were positive for COVID-19. The investigators also did antibody tests on a smaller subset of patients, about 240, and the positivity rate for antibodies was 4.2%. While we don't know why the prevalence rate in asymptomatic cancer patients was so low, especially in comparison to the positivity rate that was reported in New York City, we imagine that this is a very motivated patient population and that our cancer patients are clearly recognize that there are risk factors and are abiding by social distancing recommendations, mask wearing, and hygiene precautions that have been recommended. In terms of outcomes of cancer patients that develop COVID-19, there is a lot to learn here, and this is an area of very active investigation. And this is also a very complex area given the multiple different diseases that are represented under the cancer diagnosis, as well as the breadth of treatment modalities, surgery, radiation, cytotoxic chemotherapy, molecular targeted therapy, and immune therapy. However, early evidence suggests that cancer patients have an increased likelihood of worse outcomes versus non-cancer patients. A global meta-analysis looking at a composite of 32 studies involving over 45,000 patients across the globe in Asia, Europe, United States, suggested that the all-cause mortality was higher in patients with cancer. So a recently presented experience of 120 United States cancer centers also suggests that cancer patients have a higher rate of complications due to COVID-19, including hospitalizations, requiring oxygen, admissions into intensive care units, mechanical ventilations, and death versus non-cancer patients. Those patients that receive chemotherapy within the past 12 months may also be at increased risk. Pandemic has impacted medical care for all Americans. A Time magazine survey suggested that 40% of Americans were unable to get some kind of medical care due to the pandemic. We have all seen and documented that there have been decreased ER visits. New oncology consultations have decreased by 50% through March and May at academic medical centers. While volumes have currently picked up and primarily due to the utilization of virtual visits, we still believe that there have been many patients have been unable to get the medical care that they have needed during the pandemic. Cancer patients have also experienced disruptions in their care. Cancer patients and their physicians have the difficult task of weighing the risk of severe illness with COVID-19 for an individual patient versus the urgency of their cancer care. Patient surveys have documented that cancer patients have delayed starting chemotherapy and radiation due to the pandemic. The impact of this on cancer outcomes is still unknown. Many expert guidelines have been generated during the pandemic to help physicians and their patients weigh the risk of starting cancer treatment during the pandemic versus the patient's individual risk of severe COVID-19 disease. There's also been a large impact on cancer screening during the pandemic. There have been 60% fewer screening exams for breast, colon, and cervical cancers from March to mid-June. And while that has increased back up to 80% capacity, we're still not back up to the pre-COVID-19 levels. It is too early to know the impact, but some predict that these delays may cause an excess of 10,000 deaths from breast and colorectal cancer in the years to come. Thus, I think all of us in medicine are definitely wanting patients to return to care, and hospitals and medical centers have instilled safety measures, universal masking, as well as social distancing requirements to make returning to care as safe as possible for our patients. There is a lot to be learned about how the COVID-19 pandemic has affected our oncology patient population. This is an area of active investigation. The COVID-19 and Cancer Consortium is a group of 120 cancer centers that are actively entering data to study this effort. Additionally, the NCI has launched its COVID-19 and cancer patient study, which is a prospective study enrolling patients with recently diagnosed COVID-19. Our professional societies, the American Society of Clinical Oncology, as well as the American Society of Hematology, have also launched registries that will hopefully add to the information about how COVID-19 has affected our oncology population. I appreciate the opportunity to discuss this with you, and thank you very much.